2 receptors as well as the co-receptor for attachment of the spike protein is present in the islet cells. And during cytokine storm, there is insulin resistance. So there is an increase in the insulin requirement. And whoever has treated this COVID-19 knows that the most difficult aspect of treatment of COVID in diabetic individuals happens to be controlling the blood sugar levels, which can go up as part of this COVID-19 per se, and can also go up as part of the treatment modalities that we are using, like the steroids in hypoxemics, as well as tocilizumab, this IL-6 receptor antagonist, and to an extent, and the baricitinib as well as tofacitinib is available. We have not started using it as of now, but soon we'll also be starting using those drugs. So the immunosuppressants and steroids can lead to the mucormycosis, especially steroids and dysglycemia associated with that. So COVID-associated mucormycosis. Since the onset of COVID-19 pandemic, multiple reports across country of very high incidence of mucormycosis among patients with COVID-19, especially in those with diabetes and those who have received steroids. And this is referred to as the CAM. It's associated with high morbidity and mortality. And the mortality of mucormycosis is around, say, 40 to 80%. So, and in patients with uncontrolled diabetes, diabetic ketoacidosis, it rapidly progressed to become disseminated mucormycosis, and patients may end up and DIC and all, and patient can die within, say, within a week of diagnosis in case of patients with diabetic ketoacidosis. So we should know that the mortality associated with invasive mucormycosis is around, say, 40 to 80%. And when should we suspect COVID-associated mucormycosis? So in our experience over the last 6 months, in Trivandrum Medical College, we saw around 7 cases of mucormycosis. As of now, we are having one patient admitted in the hospital. So it can occur actually as along with this COVID-19. That is, the concomitant infection can occur. That is usually due to associated diabetic ketoacidosis and all, and can occur in a sequential fashion. Okay, sequential fashion means that the patient has recovered from COVID-19, and later patient is actually presenting with features suggestive of Rhino, Orbital, Cerebral mucormycosis or pulmonary mucormycosis. Usually, the mucor can present as Rhino, Orbital, Cerebral or pulmonary mucormycosis, the gastrointestinal mucormycosis, the cutaneous, the primary cutaneous mucormycosis, or as a part of disseminated mucormycosis. So what we are commonly seeing is the Rhino, Orbital, Cerebral as well as to an extent the pulmonary mucormycosis. The GI mucormycosis is common, is observed in neonates with a very bad outcome, especially in those patients receiving patients on treatment for leukemia and all. And disseminated mucormycosis usually seen in post-transplant setting and patients with diabetic ketoacidosis. And cutaneous mucormycosis, once in a while we do see the primary cutaneous mucormycosis in the immunosuppressed. So how will we diagnose this Rhino orbitocerebral mucormycosis? We know that initially the patient will be having the sinusitis, the symptoms of sinusitis. So the nasal blockade will be there, and the nasal discharge, which will be bloody discharge or a brown or blackish discharge or the local pain, that will be there, and unilateral facial pain or numbness if the nerves are getting involved, unilateral facial edema, then the lid edema will be there, headache and orbital pain will be there, and toothache may be there. Sometimes now it may be of origin, maybe from the tooth. So the toothache can start as toothache, loosening of maxillary teeth, can have a jaw involvement, and when it spreads into the orbit as well as the eye, you can have the involvement of the extraocular muscles, leading to double vision, paresthesia, skin lesion, and the most important aspect, why we are calling it the black fungus and all, is because the classic feature of mucormycosis is angioinvasion. So angioinvasion can lead to the necrosis and thrombosis, and you are having this black crust that is the eschar. But we should keep one thing in mind: this black fungus is actually a misnomer, because black fungus is actually a term used to refer to those fungi which has this melanin in the cell wall. This is a Phyllophora species. The mucor is referred to as black, this fungus, because of the black crust which is associated, which is seen in the nose, the palate, the skin, etc. And coming to the second, that is the pulmonary mucormycosis. In our setting, actually diagnosing Rhino orbitocerebral mucormycosis is not very difficult, because our ENT surgeons as well as the internists are, at least in the medical colleges, are used to seeing cases, or at least say around 15 cases of mucormycosis a year. So they know to diagnose the Rhino orbitocerebral mucormycosis based on the clinical findings itself, how to suspect it and all. But when it comes to pulmonary mucormycosis, you require the support of the radiologist as well to have a guided biopsy, which in the setting of COVID-19 may not be that easy. The common presentations will be the patient will complain of fever, cough, chest pain, pleural effusion, hemoptysis, worsening of respiratory symptoms and all. And the lung CT, so usually the problem is that usually when you are seeing a nodular cavitating lesion in a patient, so maybe into the third week of COVID-19 infection, so the DDs that should crop into your mind is whether the patient is having a COVID-associated pulmonary aspergillosis or a TB reactivation due to use of steroids or tocilizumab. You should also keep in mind the possibility of pulmonary mucormycosis. So there are certain radiological differences. And then usually in order to diagnose this COVID-associated aspergillosis, we are using markers like say galactomannan and beta-D-glucan. And these markers are negative in mucormycosis. So galactomannan is fairly specific for diagnosis of aspergillus. Beta-D-glucan is actually a pan-fungal cell wall marker. Both these markers are negative in mucormycosis. So these are certain examples. So the lesions will appear. You can see the first one is an implantation mucor, that is following a road traffic accident. You can have these spores getting implanted into the wound, and you can have the necrotic lesions. So if you are seeing a black lesion with erythema, with severe pain, you have to think in a patient who is immunocompromised, you have to think in terms of mucormycosis. The second one is you can see the lid edema, the erythema, as well as you can see the ptosis is also there. So means that it has extended into the orbit as well as the eye and the extraocular muscles are involved. And from there, it has extended into the cavernous sinus, and probably it can extend into the brain, can lead to meningitis as well, and skull-base osteomyelitis. And the D is actually, you can see the palatal. In the palate, hard palate, you can see the palatal necrosis, or you can see the black crust in the palate along with the blackish discharge and purulence. And the E is actually in a neonate treated for lymphoblastic leukemia. You can see the extensive cutaneous mucormycosis, which is extending into the orbit as well as into the brain. And this is in a neutropenic individual. There is F is in a neutropenic individuals is having necrotic skin lesions with the sinusitis, which is extending into the eye. And G is actually the classical eschar-like thing in the name. That is, if you are seeing such a lesion in a patient post recovery from mucormycosis who has been a diabetic with uncontrolled blood sugars, has received steroids and say tocilizumab like that, if you're seeing a necrotic lesion like this, need to think in terms of mucormycosis. So this is actually all the training sessions that we have been conducting for the DHS, the doctors of Kerala, right from the last 3 months or so. We have been using this slide because we were aware of this diagnosis of mucormycosis, because we did have patients, initial 3 patients with mucormycosis landed up in Medical College Trivandrum from Tamil Nadu, and they were diabetics, and the reason was the dose of steroids used was pretty high. We know that even in severe COVID-19, the dose of methylprednisolone should be 1 to 2 mg per kg per day. So they were actually pulsed with 1 gram of methylprednisolone, and another patient required maybe around 500 milligram methylprednisolone per day. So high doses of methylprednisolone, steroids being given with uncontrolled blood sugars is actually a recipe for disaster, as the patient can develop mucormycosis, as is evident in this case. You can see the lesions in the palate, which is extended into the sinus, and from there into the orbit, the eye, and the patient had cavernous sinus thrombosis. And this CT lung is suggestive of a necrotic cavitatory lesion, which is pulmonary mucormycosis. So why the patients with COVID-19 are developing mucormycosis? I don't believe that, because every year we used to have around 15 cases of this mucormycosis in patients. Majority of them are having uncontrolled diabetes mellitus. And then in certain situations, in those on chemotherapy, post-transplant patients and all. The COVID per se, I don't think will lead to an increase in mucormycosis. It is actually related to the uncontrolled blood sugar levels. Actually, when we look at our data in the COVID era, our mucormycosis cases are actually lesser and compared to 2019 and all. But then from my friends in Maharashtra, Delhi, etc., they're having a lot of cases of mucormycosis. Probably when the cases increase, we are not able to pay that much attention to the glycemic control, and probably and unregulated use of steroids, especially the dose of steroids, and then the onus on IL-6 antagonists like this tocilizumab, etc. Probably for intense immunosuppression along with dysglycemia is leading to sort of a wave of this mucormycosis in the rest of India. And we are also seeing our share of cases. So what happens is in severe COVID-19, they're having a dysregulated innate immune response. There is ciliary dysfunction. There is cytokine storm. There is thromboinflammation. There is microvascular coagulation and immune exhaustion or immune paralysis in the patients who are having severe COVID-19. So majority of them will be in the ICUs. So in the ICUs, there is increased risk of sepsis, bacterial as well as a fungal sepsis, due to the number of invasive procedures done, the CRRT done, the need for ECMO in certain patients, mechanical ventilation, poor nursing ratio. This is a major problem in the COVID era. The nurse-patient ratio is sort of skewed, and because of that, there is a compromise or breach in the IPC measures, and the use of drugs, the immunosuppressants like steroids, tocilizumab, and JAK193 inhibitors like baricitinib and tofacitinib. And to top it all, our climate, that is a tropical climate, means that we are having more spore count in our hospital air, especially when there is a construction activity going on. It will be full of fungal spores, which includes the spores of aspergillus as well as spores of mucormycosis. And why dysglycemia leads to increased propensity for development of mucormycosis? When the blood sugar is actually more than 200 milligram, there is an increase in the endothelial glucose regulator protein 78 expression. So when this is actually the receptor in the endothelium to which this the mucor hyphae will attach. So when there is a GRP78 expression, so it becomes easier for the mucal hyphae to attach to the endothelium and can lead to angioinvasion, necrosis, and the formation of the classical the crust or the black crust. And when the sugars are more than 200, you are having this polymorpho neutrophil dysfunction, impaired chemotaxis, defective intracellular killing, and all these things will predispose to a bacterial or an invasive fungal infection. And if the patients are receiving steroids or say tocilizumab, etc., there is an impairment in neutrophil migration, ingestion, as well as phagolysosome fusion. And steroids also can lead to actually steroid-induced dysglycemia, and this can also contribute to a possibility of a development of mucor. And if the patient is having diabetic ketoacidosis, so this mucor, that is Mucoris, Rhizopus, abscidi, etc., requires iron for its growth. So when there is acidosis, when there is diabetic ketoacidosis, there will be increased iron in the serum for utilization by mucor. So it becomes.
Aravind sir, please unmute sir. Aravind sir.
Oh, appo iduvare onnu kettille.
Kette ippa.
Oh, ippana. Okay. So all these things actually will contribute. That is a setting of diabetic ketoacidosis actually means that there is increased iron, and this iron will be taken up by the sideropores or the iron permeases in the mucor and can actually grow faster and can lead to disseminated mucormycosis. So diabetic ketoacidosis is something which we need to avoid in patients with COVID-19. So how to diagnose mucormycosis? So clinically, Rhino orbitocerebral mucormycosis actually because of the rapidity of progression, so unilateral facial edema, so ptosis, the crust in the nose, etc., we may be able to identify. But we should keep one thing in mind. So it is a medical emergency, and even when clinically suspected, we probably, even prior to confirming the diagnosis, we may have to start the patient on definitive treatment. So whenever we are suspecting mucormycosis, so the patient has to undergo the appropriate radio imaging study. So either the CT or the MRI PNS with brain contrast to diagnose the orbitocerebral mucormycosis, and a CT thorax for pulmonary mucormycosis. And in order to confirm the diagnosis, so we need to have the specimen. So it can be collected. This is a debride the tissue or the biopsy, or through FES you can take it and do the KH mount and HPR, as well as you can do the microscopy. So the diagnosis of Rhino orbitocerebral mucormycosis is not a major problem. So along with demonstration of the hyphae, there's a broad accepted hyphae, below with tissue necrosis, it will give a clue towards the diagnosis of mucormycosis. But when it comes to the diagnosis of pulmonary mucormycosis, you need to rely on BAL or mini BAL or CT guided biopsy from the lung lesion, and then you have to stain it by KOH or by say PAS or Gomori methanomin silver stain, etc. But then the patient, if the patient is in the ICU doing the BAL, mini BAL, or CT guided biopsy may not be possible in the current scenario when the patient is having COVID-19. So we need to look at clues from the HRCT thorax as how to differentiate it from say COVID-associated pulmonary aspergillosis and all. So we'll be discussing during the radiology session. And the usual markers that we use to diagnose COVID-associated pulmonary aspergillosis, electromenin and beta-D-glucan, will be negative in the setting of mucormycosis. So these are the signs on CT thorax. So the diagnosis of this Rhino orbitocerebral is not that difficult because you have to suspect it. Then you need to do FS, and you stain it.
Yeah.
From culture also you can get the diagnosis. But when it comes to the pulmonary mucormycosis, so getting the sampling the tissue, getting a BAL done in the setting of COVID may not be that easy. Suppose the patient is coming, say a patient is discharged, and maybe 1 month later is coming with a nodular cavity lesion, so all these things maybe there's biopsy, etc., can be performed. So these are the clues in the CT thorax. So any patient who has been treated for COVID-19 is coming with a nodular cavitating lesion. We know that this nodular cavitating lesion is actually is not a classical sign seen in as a part of this COVID bronchopneumonia. So if there is a nodular cavitating lesion, we have to think in terms of a COVID-associated pulmonary aspergillosis or a reactivation of TB, which can occur in the setting of use of steroids or tocilizumab. Sometimes means bacterial infections like nocardia or pulmonary mucormycosis. So halo sign. So halo sign actually means that around a nodular infiltrate, you are seeing the ground glassing. So like a halo. So halo sign is actually a classically described in neutropenic individuals with angioinvasive aspergillosis, but halo sign can also be seen in pulmonary mucormycosis. But the sign which is more in favor of a pulmonary mucormycosis from CT is the reverse halo sign, which is otherwise known as atoll sign, which actually means that this ground glassing is surrounded by a nodular lesion. So nodular infiltrate, in the middle of that nodular infiltrate, you are seeing the ground glassing. So reverse halo sign you are seeing on CT means that it is more in favor of it being a pulmonary mucormycosis. And the next one is, so if you are doing a CT angio, which is highly unlikely, you can see that evidence of vascular occlusion by the cutoff side. So the vessel which is going into the lesion, so there may be a narrowing. That means that there is sort of a necrosis occurring and it is blocked by the fungal tissue. And the hypodense sign on MRI, these are all clues towards it. And another important aspect is the contagious spread on the CT. That is the presence of a mass or a consolidation, and which is invading into the adjacent organs, which is not respecting the tissue planes, which is invading into the chest wall, invading into the diaphragm, invading into the pleura, spleen, etc. So means that is likely to be mucormycosis. Aspergillus usually won't invade like this. TB also won't invade like this. And a rapidly progressive nodular cavitating infiltrate. So it's also more in favor of a mucormycosis and angioinvasive aspergillosis. Having said all these things, so the features between a COVID-associated aspergillosis and mucormycosis favor the features which are favoring more, which are more in favor of mucormycosis will be: one is the reverse halo sign. Second is the presence of pleural effusion with say hemoptysis, and third is the presence of more than nodules. Presence of more than 10 nodules is also more in favor of mucormycosis. If there is presence of centrilobular nodules, it is more in favor of aspergillosis. If there is evidence of a tracheobronchial invasion, that is thickening of the bronchial thickening is there, or peribronchial collection, etc. is there, it's more in favor of aspergillosis. We should know this because getting a CT guided biopsy during this scenario may not be easy. So the differentiating between say a kappa and mucormycosis may be dependent on radiological findings. So now coming to the histopathological diagnosis, so you are getting the tissue. So getting the tissue and you are staining with say GMS stain or the PA stain. So usually this is the first one, that is A is, you can see the broad acceptate hyphae. So the presence of the broad acceptate or posiseptate hyphae is actually in favor of mucormycosis. It is broad, it's a ribbon-like thing. So, and the diameter is around 6 to 16 microns, whereas in aspergillus, you can see that This is a septate hyphae with dichotomous branching, and the size is around 2 to 6 microns. So this is the calcofloor image in the mucorales. You can see it is a broad aseptate hyphae, whereas in aspergillosis is a narrow, a septate hyphae with dichotomous branching. Now coming to the treatment of COVID-associated mucormycosis is basically a team effort. You need to have if you are having an ID specialist, well and good, or else you should have an internist, you should have a microbiologist or a pathologist, so that the diagnosis can be confirmed at the earliest. You should have an intensivist, you have to have an ENT specialist, ophthalmologist. Basically, it is a team effort. The most important aspect is that you need to control the diabetes, and you should prevent the patient from going into diabetic ketoacidosis. If the patient is on, say, steroids or other immunosuppressants, so you need to take a call on that. You need to discontinue it rapidly. And if the patient is on immunomodulating drugs like, say, baricitinib, tofacitinib, tocilizumab, etc., you need to stop it. And the most important aspect is that if you want the drug, that is amphotericin B is the drug of choice. If you want the drug amphotericin B to act, you have to have extensive surgical debridement, because if in the necrosed tissue, the drug is not going to work. So you need to have extensive surgical debridement. It should remove all the necrotic material. If the eye is involved, probably the ophthalmologist should think about evisceration or exenteration of the eye. And if there is a pulmonary lesion, if it is located to one lobe, you need to think about removing that lobe, etc. And medical treatment, you know that amphotericin may have to be given for, say, weeks or months together, the maximum tolerable dose. So a PICC line or a central venous line may be considered. And in order to prevent the toxicity of amphotericin B, we need to hydrate the patient. So we need to preload the patient with, say, 1 liter of saline. And after giving amphotericin also, we need to postload the patient with 1 liter of saline. And coming to the antifungal therapies, maybe around, say, 3 years back, we just had our amphotericin, that is the conventional amphotericin B deoxycholate, or the liposomal amphotericin, or the lipid complex amphotericin. But we are having 2 new triazoles. We have been using this posaconazole, the syrup, for around, say, 2 to 3 years now. Now we are having access to IV posaconazole as well as the tablet form of posaconazole. And the new one, that is the isavuconazole, IV as well as the tablet form, is also available. So the primary treatment is definitely going to be with liposomal amphotericin. So if there is involvement of the brain, you need to give 10 mg per kg per day. If it is just pulmonary, you can get away, probably think about getting away with a dose between 5 to 10 mg per kg per day. The diluent is 5% dextrose. So it has to be diluted in 200 ml of 5% dextrose and has to be infused over 2 to 3 hours. But the problem is that we know all the guidelines do recommend liposomal amphotericin B, because the toxicity of liposomal amphotericin B is actually much less compared to amphotericin B deoxycholate. But the problem is 50 milligrams will cost around 3,000 rupees. So if you're thinking about giving, say, 10 mg per kg to a 50, so to a 50 kilogram patient, so it may come to around, say, 500 milligrams. So you can just see cost around, say, 25,000 to 30,000 rupees per day. So majority of our patients may not be able to afford liposomal amphotericin B. So we are stuck with amphotericin B deoxycholate, or the conventional amphotericin B, which 50 milligram will cost around 250 rupees. So efficacy wise, both are almost the same. The toxicity wise, you know that nephrotoxicity of the amphotericin B deoxycholate is actually more than that of liposomal amphotericin B. But having said that, we have enough and more experience with conventional amphotericin B. If you're actually preloading the patient with 1 liter of saline and then giving this amphotericin B deoxycholate 1 mg per kg is 50 milligrams at the rate of 0.08 mg per kg per hour, that is, we give the infusion over 10 hours, followed by, say, 2.0 ns later on. And if you're monitoring the potassium levels, the magnesium levels, and the creatinine daily, so you can try to give maximal amount of conventional amphotericin B. And once the creatinine goes beyond 2, then we will think about liposomal amphotericin. The thing is that tubular toxicity will set in and patient will develop hypokalemia. So in order to, we need to correct the hypokalemia as well. And if the hypokalemia is not getting corrected with, say, IV potassium as well as potassium magnesium citrate, then you need to look at the magnesium levels as well. Now, coming to the salvage therapy. So some patients won't improve with this thing, amphotericin alone. Now we have the option of adding either posaconazole or isavuconazole. So the posaconazole means you have to, if you are using intravenous posaconazole or tablet form of posaconazole, you need to have 300 milligram BD on day 1 followed by 300 milligram daily. If you are using isavuconazole, you need to give 200 milligram etholi for 2 days followed by 200 milligram OD. So usually we are using it for salvage therapy when the response to amphotericin B is suboptimal. The second situation is that you are giving, say, 3 weeks of amphotericin or 1 month of amphotericin. And then if you want to continue a suppressive dose of antifungals, we switch over to posaconazole or isavuconazole. Another setting, maybe if the patient is unable to tolerate amphotericin, is developing say sort of anaphylaxis, or the patient is having renal failure to such an extent that we cannot give the patient amphotericin B. In such a situation, we'll think about isavuconazole. So intravenous isavuconazole followed by oral isavuconazole. All these drugs are available in Kerala. Then we need to monitor the patients clinically with radioimaging for response, disease progression, and if possible, we need to demonstrate microbiological clearance. We give around 3 to 6 weeks of amphotericin B consolidation therapy, followed by posaconazole or isavuconazole for around 3 to 6 months. So all of you are invited to go through the global guideline on treatment of mucormycosis. This was released in 2019. So this is very difficult to see. This is taken from those guidelines. The more salient features are already covered. The most important thing is that previously we used to build up the dose of amphotericin B. That is, we used to give 1 milligram per kg initially, then 5 mg, 10 mg like that. But since this mucormycosis is a medical emergency, now the current consensus is that you should not slowly escalate the dose of amphotericin B. You need to give the maximum dose on day 1 itself. So this is something which we have discussed. So any patient with a nodular cavitating lesion post-COVID, we need to think in terms of COVID-associated pulmonary aspergillosis versus TB versus mucormycosis. To rule out TB is very easy. Go for sputum AFB as well as the CBNAT. Aspergillosis, getting a BAL done may be difficult, so we rely on the galactomannan levels. So ideally, you should do the BAL galactomannan. So if you're having an access to the CT guided biopsy, that will be the best one to differentiate between a kappa versus mucormycosis. But then usually it may not be possible. That is when we rely on the radiological appearance, and the radiological appearances favoring mucormycosis we have already discussed. And then 2 caveats. One is, suppose you are doing a galactomannan, if it is coming as positive. So the problem here is that galactomannan can become positive, falsely positive in many situations. Suppose your patient is on piperazole, generic piperazole and azobactam, can also lead to false positive galactomannan. Actually, the patient may be having pulmonary mucormycosis, but since the galactomannan is elevated, you will think that the patient is having aspergillosis and may start the patient on origanazole. The problem is that origanazole won't cover for mucor and can actually flare up the growth of mucormycosis. That we should keep in mind. And the most important thing is how to prevent this infection. So actually it is related to the dysglycemia. So any patient with COVID-19, we need to ensure that the patient is having a tight glycemic control. And when we are using steroids, we should be using only the protocolized dose of steroids. And then any patient who has been given steroids or tocilizumab or say baricitinib, etc., we should be on the lookout for this. If the patient is complaining of say sinusitis-like thing, and if there is facial edema, we need to think in terms of a diagnosis of mucormycosis also. And then we had around 5 patients. So the 2 patients we have not added. So we have 5 patients. So you can see that the lesions, one is, you can have the Rhino orbital cerebral, the eye is involved, this is the palatal. You can see the black crust. The endoscopic findings, you can see the black crust, this favor of mucormycosis. So 3 of them were Rhino orbital and 2 were Rhino cerebral mucormycosis. We never had a pulmonary mucormycosis, probably because it's not that easy to diagnose pulmonary mucormycosis. And compared to the Rhino orbital or cerebral forms, the pulmonary mucormycosis is relatively rare, probably because we are not identifying pulmonary mucormycosis. So this is how the lesions will look like in endoscopy, as well as the debrided tissue will look like this. So most important thing is that aggressive debridement is very, very important. So giving isavuconazole or amphotericin B without aggressive debridement, it is not going to reach the site of action. So it is necrosed tissue, means you have to divert a blood supply. So you need to remove the devitalized tissue, extensive debridement. Then only the antifungals are going to work. And this is one atypical case. One important difference between COVID-associated pulmonary aspergillosis and mucormycosis is usually this kappa is seen only in those patients who are having severe COVID-19. Majority of them would have been in the ICU, etc. Whereas mucormycosis, there's a post-COVID, there's a CAM, COVID-associated mucormycosis can occur even in patients with mild COVID-19 infection, because this is actually related to the dysglycemia rather than the severity of COVID-19. So this lady actually is a 49-year-old female with allergy to multiple drugs. She never had any history of, she had sort of a chronic sinusitis-like thing, but she never had any history of diabetes or anything. She presented with epistaxis and unilateral headache, and she gave actually history of a sort of a, it's not a severe pneumonia, she gave a lower respiratory infection-like thing around say 3 months back. There was no history of diabetes. And actually the CT chest was done. It showed so a sort of a ground glassing, which made us suspect that this patient had COVID in the past. That time it was not diagnosed. And the antibody was done, and COVID antibody was positive, because now PCR everything was negative because she had these symptoms around 3 months back. And now the endoscopy was done. You can see the black crust-like thing, and the patient had mucormycosis. Okay, it was diagnosed as mucormycosis, and this biopsy specimen showed the acceptate hyphae mucormycosis with the skull base involvement, and aggressive debridement was done. She was started on liposomal amphotericin followed by isavuconazole, and now she is doing pretty well. So this is just to highlight the fact that this patient never had a severe COVID-19. She was actually even not diagnosed with COVID-19 at that time. Even followed mild COVID-19 infection also, patient can present with say mucormycosis later on. So we need to keep this in mind. So this thing, you can see that in this case we had used isavuconazole. The problem with isavuconazole and posaconazole are that they are a bit expensive, but not as expensive as liposomal amphotericin B. If you are using conventional amphotericin B for treating mucormycosis, then isavuconazole and posaconazole are expensive, cost around 10,000 rupees per day, the intravenous form. Whereas if you are using liposomal amphotericin B, compared to that, these drugs might appear cheap. So now coming to a certain misinformation and misleading aspects which is being spread in the social media. So one is this mucorales. That is, a mucor is actually not a black fungi. So black fungi is a different category of fungi having melanin in the cell wall. This is referred to as black fungi because of the black crust, which is characteristic of the lesion. Actually, the characteristic, the melanin in the cell wall or the black thing in the pigment in the cell wall is seen with the Phyllophora species and not with zygomycosis. It is not contagious. It does not spread from one person to another. We should know that. It is not spread by this oxygenation, humidifier, and water. The fungi remain in the indoor and outdoor environment. The spores enter the respiratory tract via air. There were concerns that initially it is because of the use of this high flow nasal oxygen that, if the humidifier, the water, etc., they are using so the tap water instead of distilled water. So it may be having the fungal spore, and that is the reason why you're having that much of mucormycosis in India like that. But usually the fungal spores are there in the environment, and if there is dysglycemia, are likely to get infected. Okay. And the next is, then if it is such a big problem, why can't we give antifungal prophylaxis with syrup posaconazole or tablet posaconazole like we are doing in during bone marrow transplant and all those things? But the important aspect is that it is not a very common thing. The COVID-associated mucormycosis is not very common. Even from our experience, we had only say till now 7 cases of mucormycosis, and usually we have around say 15 to 20 cases in a year. So it's not very common. Only thing is that any patient with a cavitary nodular lesions following COVID-19, you should think in terms of that. Any patient with sinusitis, you should also think in terms of mucormycosis. So that is the take-home message. Now, no antifungal prophylaxis is recommended as the incidence is not more than 10% in any COVID-19 cohort. The incidence is more than 10%, definitely the patients will merit from antifungal prophylaxis with posaconazole or isavuconazole. So thank you very much for patient listening.
Sir, very good presentation and a very good eye-opener, sir. I think most of our specialties, neurology, ENT, ophthalmology, physician, intensivist, most of us are going to see these cases in the coming days. So definitely we should be aware, and we should be knowing about this. I think even I am now receiving inquiries regarding where this amphotericin B is available. Just now a colleague called me and asking me, he got an inquiry from Gujarat asking for 50 vials of amphotericin B. Just now I was searching for the chemist name in my phone. So definitely this is an eye opener and informative session. I request the participants, if you have any doubt, you can clear with Dr. Aravind sir. You can unmute and ask your doubts. You can put a hands in the chat box also.
Yeah.
Or you can put question in the chat box.
Yeah, Dr. Anish, I would like to ask a question. I have a query. Dr. Adarsh here.
Others.
Yeah.
Please,
Aravind sir, it was a very nice presentation. I just wanted to ask, just highlight a query. That is, in the last slide, it was you said that it is not contagious from one person to another. So, so when we have to debride this mucormycosis related tissue, so we will be using our general instruments, OT instruments. So, is there any chance that proper disinfection of the instruments, if not done, you can pass the infection to another patient? Do you have to have a concern regarding that?
actually, I mean, it's not a really a major concern, because now we are daily encountering with this is a ubiquitous fungi is present in the environment. You know that Aspergillus spores also, every day we inhale around 200 spores of Aspergillus, but then our immunity will keep these things in check. Likewise, we are also exposed to this the spores of the Zygomyces as well. So it depends on your immunity as well, and who is going to develop this mucor, especially the implantation mucor following a road traffic accident and all. So, you know, from the soil and all, you are getting exposed to this mucor, but all the patients are not developing the implantation mucor. Depends on your immunity as well. And regarding the contamination and spreading from one person to another through the equipments and all, this actually can be easily be destroyed by the usual disinfection itself. So it's not a major concern at all.
Okay, okay. Thank you, sir. Thank you.
Dr. Shamamada, you can ask your question.
Hello, sir. Good evening, sir.
Good evening.
Sir, I'm from Belgaum, Karnataka. Very good presentation, sir. Thank you. Now, this is a practical question that I'm facing from last 1 week. Even in our center, we have seen some 8 to 10 cases now. Now, what is happening, sir, is these patients who are coming, they are RT-PCR positive with CT scan severity being 15, 16 and all. And anesthetists are not willing to give the case. So how do we go about it, sir, when the RT-PCR is positive and when the severity score on CT scan is high, and when the eye is already involved? It is, I mean, we are also not brave enough to go ahead and do the debridement. How to go about these cases, sir?
It's actually a very tough question to answer, because the initial article means on COVID-associated mucormycosis, which came in JAPI around 6 months back. It's from Uduja Hospital, Dr. Rajiv Soman and Aisha Sunewala. The title itself was from the frying pan into the fire. There they have clearly mentioned. So how to time this aggressive debridement? Because any surgery, when it is done during an active COVID infection, the outcomes are pretty poor for the patient also. Okay.
Okay. Wanted to take a patient, he turned out to be positive with high CT scan score. So we are really facing a lot of problem about this, because anesthetist is not willing to give the case, and we are not brave enough to go ahead and do on a positive patient. So it is a very dicey situation that we are facing here.
Have you observed means whether these cases are related to means a very high dose of steroids used and all?
They are coming from different centers, sir. They are not from one single center or anything. Of course, they are all sugars above 300, HbA1c is 12, 13. And we don't know about their steroid dosage. In that one patient post-COVID, he did not give any history only. When we did a screening RT-PCR, he's turned out to be positive. Of course, the sugars was very high. So I'm not having any conclusion regarding the steroid dosage that was given to them. I mean, how irrationally it was used, I have no idea about that, because they're all treated from various centers in a government hospital. So no documents about what steroids were given and for how many days and the dosage of the steroids.
Okay, thank you, madam, for sharing your experience. And I would like
Yes.
to add one thing which Dr. Anish did say.
Yes,
Because
sir.
the entire country is being gripped by shortage of amphotericin, isoconazole, and posaconazole.
Definitely, sir. We do not have liposomal now at our center. It is only the lyophilized amphotericin that is available.
Okay. So as far as Kerala is concerned, till now, mucormycosis, the number of cases were pretty low. But then the way forward for us will be, since in amphotericin everything might be out of stock in the near future, we go for aggressive glycemic control. So
Yes, sir.
as a step in the right direction, our state guidelines, the last chapter is devoted to glycemic control in COVID-19.
Yes, sir. Yeah, yesterday also one patient whom I had done an orbital decompression day before yesterday. Yesterday she developed a stroke, and it was a massive thrombus involving the MCA and ICA. And we were thinking we'll do a thrombectomy because patients were quite affordable. But then the interventional radiologist was against it, and now we are only treating conservatively. It is a massive stroke.
Okay.
So these are all complications.
Patient is going to go.
Yes, sir. Yes, sir. That's what.
That's the problem. That's the problem with mucormycosis. In DK
Yes, sir,
patients,
yes,
it can be very aggressive. We will lose the patient within days.
Yes, sir.
Thank you.
Yes, thank you. Thank you so much. Yes.
Dr. Ajay.
Hello. So very good presentation. So I just want to ask two things. I'm a dermatologist from Kollam. So I just want to know, like, is there any association between increased use of itraconazole, especially like patients with diabetes, like we use it for tinea and all? Any link between this use of itraconazole and selection of this mucor? Because itraconazole actually does not work against this mucor. So is there any selection and increase in cases due to increased use of itraconazole in patients of diabetes? So my second question is like, is there any role between like this right now, like due to this shortage of oxygen, we are using this industrial grade oxygen. So industrial grade oxygen, is it increasing the risk of mucor?
Actually, coming to the first question, what we know for sure is that voriconazole will select for mucormycosis. What happens is, there is a competition between different fungi for survival. And when we are using drugs like say itraconazole or voriconazole, which may take care of all other fungi, and the mucor, which is not covered, will become the dominant population. And if there is a chance for invasion, so mucormycosis will set in. So what applies to voriconazole will apply to itraconazole also. The same thing applies to the use of these broad spectrum antibiotics. So usually in our skin as well as the gut. So and in the skin, usually the mucor will be there along with the other fungi as well as bacteria. So broad spectrum antibiotics will kill off the bacteria, and the itraconazole or voriconazole will kill off the other fungi, and the mucor will become the dominant population. Usually it does not have that much of a survival advantage. So we make it strong fungi by killing off the other bacteria as well as other fungi. So itraconazole and voriconazole can lead to this. The second question with respect to the industrial grade oxygen, I believe that industrial grade oxygen is around 99% oxygen. Our medical oxygen is around 93%. But then there has been aspersions cast on the using these humidifiers and this HFNO, etc. from Maharashtra and all, but they did sampling and they were not able to find anything. The environment does play a role, and we need to keep a watch on that. For example, if a single center is having, say, around 6 to 7 cases of mucormycosis in their ICU, definitely there has to be a point source. And then as a part of outbreak investigation, we need to investigate all these things. As of now, as I said, no, it is not very easy to miss cases of Rhino orbitocerebral mucormycosis. So it's not that we are missing cases of Rhino orbitocerebral mucormycosis. We had only 7 cases, means that probably we had only 7 cases in Trivandrum, and 3 of them were from Tamil Nadu. So if it is due to oxygen or something like that, we'll be seeing more cases of mucormycosis. But what is worrying me is that what Madam says, she's saying seeing around 10 cases of mucormycosis in a week is not a joke. We have seen only around 15-20 mucormycosis yearly. In Trivandrum Medical College, and our drainage includes around say 6 districts and the neighboring state of Tamil Nadu as well. So, and there has been, usually we say it is mucormycosis, we are not going for speciation. The susceptibility testing is very difficult, can be done only from PGI Chandigarh. So actually the microbiologists are saying that if you're seeing such a huge wave of mucormycosis, we need to look at the pathogenicity and the virulence characters also. We need to see which species is causing the problem. So just by saying it is broad accepted hyphae, we cannot say it is Rhizopus or anything like that. So we need to see whether it is a Rhizopus or Absidia or Mucour or Rhizomucour. And if so, what is the species that we can do multi-top and we can send it to PGI Chandigarh to see whether it is a more virulent species. That is why, is it because of that that more number of patients are getting affected? So such studies are going on now.
Thank you, sir. Thank you, sir.
Thank you.
Any more questions? If anyone is having any question, you can unmute and ask. So there is a question.
I can see one question in the box, that what precautions should be taken when we are sending a SAF for KOH mount. Actually, what we would like to do is we have to send the debrided tissue for HPR as well as staining. I'm not really aware of the other precautions to be taken. One thing is that the tissue should not be grinded. So tissue should not be grinded, should be sent as such.
Yes, if is there any other question? Biju sir, Dr. Biju Nelson sir is there. He's our
survival percentage in Trivandrum Medical College. Okay, so out of the initial 5 patients, we lost, actually 2 of them we lost. One was a sort of a patient had diabetic ketoacidosis along with COVID-19, and patient had disseminated mucormycosis, and we lost the patient within around say 3 days or so. The second patient was one patient from Tamil Nadu, was doing pretty well, was having Rhino orbital mucormycosis, and suddenly one day patient sort of developed cardiac arrest and died. I don't know the reason. I don't think it is due to mucormycosis. The patient was having all other comorbidities. The other 4 did survive. And there is one patient as of now. She is having mucormycosis, COVID-19 along with Rhino orbital cerebral mucormycosis. And she is being treated for both together. And we had a primary cutaneous mucormycosis with went in for DIC and all. Later turned out to be COVID positive. So I don't think it is related to COVID-19. It was more related to uncontrolled diabetes than COVID.
We have our district committee chairman, Dr. Biju Nelson sir. Yes, sir.
It's a very good presentation, Dr. Aravind, and I think it's a big coverage for many of the doctors taking part in this. Okay, thank you very much.
Thank you, sir.
Yes, if you don't have any other question, we can wind up this session. Actually, our president was not able to join due to this power failure. I think in Kollam, I came to know about by night 2:30 a.m. or something like that only current will come. Our IMA South Zone Vice President Dr. Alfred V. Samuel sir also was there in this CME. Now he is not there. If no one is having any question, we can wind up the session. Aravind sir, once again, thank you. Thank you for accepting our invitation over phone and giving an overview idea of the mucormycosis. I think that was an apt time to schedule a talk regarding this. Thank you, sir. Thank you. Thank you for accepting IMA Kollam branch's invitation and joining us.
Thank you. It was my pleasure. And I would like to say that today, national level, they had said that the entire state should be trained in mucormycosis, and IMA Kollam actually is way ahead. Because I think the first training session in the state on mucormycosis.
Thank you, sir. Thank you. Thank you. Thank you, sir. Thank you for the compliment. And thank you everyone for joining the session. I think we had participants from Coimbatore, Belgaum, Bangalore, Chennai. Thank you. Thank you. Thank you one and all. Thank you, sir. We'll close the meeting. Thanks.